we're gonna cover only the innate immune system, and then, but in the lab today, I think you guys are doing ELISA. That's one of your lab activities, and ELISA involves the discussion of the cell-mediated response as well, or the specific response. Right? So we'll get to that discussion later. Okay, so as far as the immune system goes, this is basically a system consisting of physical structures and also a bunch of chemicals released out, like enzymes and proteins and stuff like that, in addition to cells inside your blood. So these cells are called the white blood cells. And we already talked about the white blood cells, right, once upon a time. So you guys should know all of these white blood cells and what they do in response to the pathogens. But now I'm going to show you how they respond to those pathogens as well, okay? All right, so for the immune system, there's actually two divisions that you guys need to know. The first one is called the innate or the non-specific immunity. The second one is called the acquired or specific or adaptive immunity, okay? So you think about the innate kicks in immediately as some kind of pathogen enters your body. The acquired or specific one takes a little bit more time because now it has to adapt to whatever is causing the most problem in your body and then responding to that problem more effectively. Okay? So it's a more calculated approach in that sense. All right, so before we get into this, there's a couple of things that you guys need to know. One is called, so this particular structure here, we refer to as the primary lymphoid organs. Anytime you hear the word lymphoid, think structures that allow for white blood cells to develop, things like that, okay? So the primary lymphoid organs includes your bone marrow and your thymus gland. And when we say bone marrow, we are obviously referring to the red bone marrow more so than the yellow bone marrow, because the red bone marrow is active bone marrow where most of these cells are being created all the time. Okay, so the red bone marrow is essentially the site of maturation of all of your white blood cells except for your T cells. Okay? The thymus gland, which is located in front of your heart, in the mediastinum, in what we call the anterior mediastinum, is more active during early childhood, and it's now almost gone by the time you guys reach adulthood. So once you reach adulthood, your thymus gland is now taken over by adipose tissue, and therefore there's very little activity that still goes on within the thymus gland itself. But while you're developing as a child, the thymus gland is highly active because it is the site of maturation for your T cells. Okay. Now, once you reach adulthood and most of these particular white blood cells has become somewhat mature, there's a second area we call the secondary lymphoid organs. Secondary lymphoid organs basically are responsible for housing a huge amount of white blood cells within the body. So secondary lymphoid organs involves your lymph nodes, or includes your lymph nodes, your spleen, your tonsils, and any area within any internal organ that has a high collection of white blood cells. We call those the mucosa-associated lymphoid tissue. Okay? Very high concentration of mature white blood cells, right? And the white blood cells here will migrate constantly from the secondary lymphoid organs to your blood and to your lymph and back and forth all the time. So we call hematopoiesis, right? You guys need to know that for the exam anyways. So you have your pluripotent stem cells, which is your hematopoietic stem cell, which then differentiates into either myeloid stem cells or lymphoid stem cells. The myeloid stem cells will differentiate into the proerythroblast and all that committed cell line, right? So we don't have to talk about that. But eventually, the myeloid stem cells will give rise to your red blood cells, to your platelets, to your granular leukocytes. So these four guys, right? Neutrophils, basophils, eosinophils. The mast cell is also developed inside the red bone marrow. But the mast cells do not stay inside the circulation. They actually leave the circulation and basically live right next to the blood vessel, outside of the blood vessel. Okay? So that's the mast cell. Everything else is inside the circulation. Okay? And then for the lymphoid stem cells, they will differentiate into your T cells and your B cells. Oh, sorry, the other cell that differentiate from the myeloid stem cell is going to be your monocytes, which then becomes your macrophages. Lymphoid stem cell differentiate into T cells, B cells eventually, and another subset called the natural killer cells. Okay? and the B cells and T cells are part of your specific or adaptive immune response. Whereas all of these cells here, the monocytes, macrophages, the neutrophils, basophils, eosinophils, and also the mast cell, to a certain extent, are part of your innate immune response. Okay? So, the cells that are part of that innate, your neutrophils, eosinophils, basophils, mast cells, monocytes. Okay? We don't need to go through what they do because we already talked about that once upon a time. I'm just gonna show you how they do it now, but for the most part, not all of their activities. So, also keep in mind that the monocytes become macrophages if they ever leave the circulation or if they come across any kind of pathogen while they're inside the circulation. And the macrophages are just these big cells that just eat up any of these particular pathogens, right? So they're phagocytic cells in the body. Now, if in development, as you're developing as a baby and things like that, if you have monocytes becoming macrophages, and these macrophages are now living in the organ system of the body, it's no longer part of the circulation, but they're now residing permanently in every single internal organ, those macrophages are referred to as the resident macrophages. Okay, so, all right, we talked about some of these resident macrophages already, right? In the nervous system, you guys remember what they are? Oh, so what's the resident macrophage in the nervous system?
Glial cells?
Which glial cell? Yeah, glial just basically means support.
Microglia.
Cell. Okay, or the microglia. All right. Now, for the adaptive, specific, or the other system, the cells that basically are part of the system are known as your B cells and your T cells. Okay, B cells, when they are stimulated, they will become plasma cells, and they will secrete mainly gamma globulin proteins, which are antibodies. When we talk about antibodies, these are very small protein structures that has very high specificity to any foreign protein substance. So therefore, it can bind to any kind of foreign substance and recruit white blood cells to destroy whatever is associated with those substances. Okay? Anytime you produce antibodies, this basically means that you now retain the memory of that pathogen that has caused infection in your body. Okay? Now remember, we talk about preformed antibodies when we talk about ABO and RH typing system, right? The preformed antibodies, anti-A, anti-B antibodies, were already formed at birth. Any other antibodies that is not called preformed antibodies will only be produced after you have been exposed to that pathogen. Okay, so let's say if you've had the chickenpox, right? You're gonna have the antibodies against chickenpox. If you ever had the vaccination for hepatitis B, you will have antibodies against hepatitis B, right? So on and so forth, things like that. Okay. All right. Now the other lymphocytes that's part of this adaptive immune system is called your T cells. The T cells are very specialized cells. They don't really do much in response to direct pathogen. They have to be presented with the pathogen in order for them to react appropriately. Okay, so their reaction, their activation is complex overall, and we'll talk about that later. And once they are active, they will release a bunch of signals called interleukins and cytokines and chemokines, whatever the case is, to massively activate the overall immune system to fight off a specific target. So the T cells are the cells you really want to activate if you want to fight off the infection of the body. Okay? And then natural killer cells is just a subset of these T cells that will rapidly respond to things like tumor cells or virus-infected cells of the body. Okay? They're not as effective as these particular guys. Now, anytime we talk about the immune system, we always use military examples because that's how our immune system is structured. So you're gonna have what we call the first tier of defense, the second tier of defense, and the third tier of defense. Okay? The first tier of defense is essentially your physical structure and the enzymes and secretion produced by your body. Second tier of defense is your innate cells. Neutrophils, basophils, eosinophils, monocytes, macrophages. Third line or third tier of defense will be these particular guys, so your B cells and your T cells. Okay? If you overwhelm these guys, that's it, game over. We don't have anything else to fight off the infection. So, first line, second line, third line, right? Now, when we talk about the immune system, we're gonna talk about them separately. So innate, we're gonna talk about separately. Specific, we're gonna talk about separately. But they do blend in together.
I watched Philadelphia again recently. So in case of like AIDS, is the body is it overwhelmed by the amount of?
Well, the thing with HIV is that virus is called a retrovirus. So once the virus enters your body, that particular one, it injects its RNA into your body. So it has an RNA as its genomic information, not DNA. But it has also an enzyme called reverse transcriptase, which then reverse transcribe that RNA into DNA. And it takes that DNA and incorporates it into your genome. So it hides away inside your cell for whatever amount of time, decades and decades, right? Depends on the overall health status of that patient. Now, one of the cells that it loves to do that to is your T cells. Imagine all your generals and all your commanders are now infected, right? So eventually, if it hides inside your T cell, it's undetectable. So therefore, for HIV patient, if they get infected with HIV, the first sign that they have is going to be some kind of fever. So they're gonna have fever, and then they clear that fever, and then the virus is very much non-detectable for a long time. And that could last for decades. And then all of a sudden, let's say they got hit with the flu or pneumonia or whatever it is, right? And one of those T cells that has that viral genome gets activated. The viral genome removes itself from your overall gene and starts to replicate itself. So now it takes over that cell. And once it takes over that cell, the cell is now infected. So once the cell is infected, it will signal to your immune system that it's infected. And your immune system will come in and kill that cell. Imagine all your T cells, or the vast majority of your T cells are infected. So you're now actually killing your T cells. So what happens is that once your T cell level drops below a certain amount, now you have AIDS. But HIV doesn't always result in AIDS, right? HIV is just a virus that affects your body. AIDS is a medical condition due to the fact that your immune cells are now so low that you're subjecting to other type of infections. So typically AIDS patients don't die from AIDS, they die from something else. They die from the common cold, they die from the flu, they die from pneumonia, they die from whatever it is, fungal infection, massive tumor that's formed by these fungi or whatever the case is. All right, so anyway, yep, so that's that. All right, let's talk about the innate or non-specific immunity first. So the first line of defense is always gonna be some kind of physical barrier, and as far as physical barrier goes, your skin is the best physical barrier that we have. So take good care of your skin. You don't have to use extra lotion because it can actually clog the pores, causes more issues in your body. Just, use soft soap or whatever the case is, basically just kind of keep it healthy all the time, okay? You don't need to buy like any kind of lotion, expensive crap from the pharmaceutical companies or anything from, the beauty supply stores and stuff like that, because that's all placebo. Might as well just take cooking oil and rub it on your body if that's the case, okay? Actually, olive oil does a very good job.
Coconut oil.
Coconut oil, actually very good too. Coconut oil has also been shown to decrease dementia because coconut oil contains what we call medium chain triglyceride, which is fatty acids in the medium chain. So they have very long chain, you have long, you have medium, you have short chain triglyceride. Medium chain triglyceride is taken by the neurons the most. And when they process that fatty acids, they will break it down, making a lot of ATP. So therefore, they're a lot more neuroprotective in that sense. There has been cases where the dementia patient has shown reversal of some of those conditions, but it has to be very early onset. Of course, you have to consume a huge amount of coconut, right? It's not like, you eat one coconut, you're protected. It doesn't happen that way. And maybe you wear a coconut shell, I don't know. But
So it absorbs it through your skin,
coconut oil, yeah, if you can put it on your skin, it's actually pretty good too.
and then it absorbs it.
No, for those you have to consume them. But you have to consume a huge amount consistently through years and years and years. Right? Not just like taking one, gulp of coconut. That's not enough. Okay, so other physical barriers that you have to prevent entry of these pathogens will be your mucosal membrane. So oral cavity, right, inside, any particular internal space of your body, you will have this added protection. Because every time you put food into your mouth, that food is contaminated already. Okay? Which means that you are now introducing pathogens into your body. But that's okay. We have a very wonderful immune system that will do a lot of wonderful things for you. All right, you also have hair and mucus secretions that will prevent invasion of these pathogens, right? The hair prevent basically the tight adhesions of some of these pathogens. The secretions will wash away some of these particular type of pathogens as well. Okay? Things like tears is important. Sweat is important. Saliva is important. Acid, bases, salts, whatever it is that's being secreted out by your body is important. So anytime you shed tears, it's not because you're always emotional, right? Like, oh my God, no more pizza, cry, sad. It's not the case. Maybe because like when you're eating the pizza, one of these pepperoni like flicked into your eyes and you're like, ah, crap. Or whatever the case is. Or maybe you rub your eyes so much, now you're introducing a bunch of like microorganisms onto your eyelids, and therefore it irritates and potentially can contaminate and cause infection. So as a response to that, the lacrimal glands will secrete tears to help wash away some of those pathogens before they tightly adhere to the surface of your cells. Once they adhere tightly, it's very hard to remove them, okay? And if they start to congregate, they can divide massively and cause infection of the body, especially if you allow them to enter deep into your skin, okay? All right, other processes like vomiting, urination, defecation, and diarrhea are all responsive processes in the body as the body is trying to get rid of any kind of toxin. So obviously, everybody pees and poop, right? But not everybody vomit all the time or have diarrhea all the time. But if you do have vomit and diarrhea, appreciate the fact that you can still vomit and produce diarrhea. Because if you can't, you're basically on the verge of death. Okay, so let's assume this, you eat something and you go home and you're like, oh, I don't feel well. Now, whatever that food is massively contaminated with these pathogens. And it's not really the pathogen that's causing the issue. Sometimes these bacteria can be releasing toxin. The toxin causes an altered cellular activities, right? And therefore, that cell is now dying because it's injured. So as a response to that, you will now vomit all that stuff out. This basically will massively remove a lot of toxins from the body as well. And of course, it's open at both ends. So therefore, sometimes it's not just the vomit, but then you also produce diarrhea as a mean to get rid of all the toxins very rapidly. So anytime you eat something and you get what we call food poisoning, right? Food poisoning is just basically a layman's term for gastroenteritis. It's just irritation of your bowel. So what's gonna happen is that within 24 hours, you're gonna be sitting on that toilet for a long time with high frequency. You're gonna go to that toilet all the time, but eventually you're gonna pass all the toxins out of the body. So within a 24-hour period, if you do have diarrhea because of food poisoning, it should clear within that time. If the diarrhea persists and now you also have fever, go to the ER. Because now it becomes a lot more severe. Because now you can actually kill the cells and produce what we call bloody diarrhea, which is a lot more invasive. Question?
So when you are going through chemo treatment,
Mhm.
you're recommended to like go pee often?
Well, when you go through chemotherapy, what happens is that it does because oftentimes there could be some kind of medication or contrast material that's injected into your body. Those things, if you don't clear from your system, basically may cause the kidneys to be acutely injured, right? And of course, as you go through chemotherapy, a lot of times the cells that are rapidly dividing, like the cells in your hair follicle, your skin, your GI tract, they are the one that gets affected the most and they will die off very fast. So that's why a lot of patients that has chemotherapy feel sick. They throw up, they have diarrhea, they also have these other issues, right? Fatigue and stuff like that. Because the body is just now being massively traumatized, they have to respond to it. So yes, one of the things that's recommended is for the patient to drink a lot of fluid. This is basically obviously to help prevent dehydration, but also to maintain adequate amount of filtration into the kidneys so you can wash away whatever potential toxins that may accumulate in the kidneys. Because those particular medications that we use for chemotherapy has to be cleared somehow. And that's the only two organs that clear any toxins from the body. One is the liver, two is the kidneys. Right? You overwhelm those, and you have to be on dialysis or you have to get a liver transplant. It's not always good. Patient with liver failure usually die from liver failure. Because if your liver is gone, you'll be dead in about 3 days. Right? There's no way you can do anything about that. Anyway, so let's think of something more happy. Pizza.
Well, your liver can regenerate, right?
To some extent. It depends on the severity of the injury to the liver, right? So let's say if it's injured like slightly, yes, it can regenerate to a certain extent. But it depends. If those cells are dead, then what they do is that they form scar tissue to surround that. So you have now nodules, but the rest of the liver cell, which is still healthy, can still regenerate, which means they have high mitotic activities, right? If in the, you can do this, the liver can regenerate a lot better when you're, let's say, an infant, right, or an adolescent. But well, I guess at my age, you guys are still young, so who knows, you guys may still have high regenerative capability. At my age, if I remove 80% of my liver, I will only have 20% left, right? It's not gonna all of a sudden regenerate into a new liver. Makes sense, right? So it has regeneration, but not in the way that we think. All right, now, for the next line of defense, which involves the cells, the white blood cells of the body, the two main phagocytic cells are known as your neutrophils and your macrophages, okay? Now, in order for the neutrophils and macrophages to recognize the pathogens so that it can bind to and phagocytose those pathogens, they have to use receptors. So the receptors on the white blood cells are known as the toll-like receptors. And the protein structure, the surface proteins on these pathogens are made by the pathogens, so therefore it is a foreign substance, right? It's not made by us, it's made by the bacteria or whatever it is, so therefore it is considered to be foreign. So any foreign substance is potentially a pathogenic substance. Pathogens means basically a foreign or some kind of abnormal type of structure that may cause some kind of infection or reaction within the body. So therefore, on the surface of these microorganisms, i.e. bacteria or whatever it is, we have these structures called the PAMPs. PAMPs stand for pathogen-associated molecular patterns, which essentially means it's a foreign protein. That's all. Molecular pattern is a bunch of amino acids forming a protein structure, okay? So your toll-like receptors on your neutrophils and macrophages will recognize these PAMPs on the pathogens, on the microorganism. It will bind and allow for those cells to then phagocytose these pathogens.
How do I know when to bind, or how to bind if during an initial infection?
For this, they don't care. They don't need to recognize that they don't care about if this is a bacteria or a virus or whatever it is. They just know it's foreign. That's all they care about. They know that these particular protein structures are not made by your cells. So therefore, if they can't recognize the fact that it's from you, they will bind to it and initiate phagocytosis. Because it's innate, they don't care. They're so non-specific, right? They only care about self versus non-self, so to speak.
Where did the toll-like receptors come from?
Just a protein expression. It's a gene coded within the DNA of these particular cells.
Okay, but they're like,
How would they recognize the PAMPs, you mean?
no, right, never mind.
Yeah. What do you mean, where do they come from? They're proteins, right? How do you make proteins?
Yeah, I know that.
Okay.
I'm saying like, how did how did it determine like what type of receptor?
Well, because on your cell, you have certain proteins, certain surface proteins, right?
Or I
So
guess,
therefore, the immune system knows every single protein that your cell makes.
Yeah,
So those toll-like receptors
yeah,
will not be able to recognize any of your proteins.
yeah, but how did they like, I guess like figure out like
What the PAMPs are?
what, yeah, like what the proteins to recognize?
Yeah, because the PAMs are not made by you. So therefore, they don't recognize that as part of you. So if it's not part of you, it's part of something else.
Okay, so it's just coded for like random ones that are not
Oh
part
yeah,
of you?
they don't care what it is. If it's foreign, they will bind to it and eat it. Okay, that's it. That's innate, right? Not specific.
Yeah,
That's all.
okay,
Right. So when it gets to specific, then it's very different. It
Yeah.
becomes highly specific.
yeah, yeah.
This is just innate, so it doesn't care. The toll-like receptors are basically made to recognize non-self proteins. That's all. It doesn't matter what it is. It has all of these, because they have different types of toll-like receptors in different neutrophils and macrophages.
Yeah,
So it's not like every single neutrophil has every single toll-like receptor for every single pathogen. Right? So therefore, you have subsets of all of these neutrophils that's out there.
okay,
So therefore, they will come across a PAM that they know that it's not part of you.
okay,
And if that's the case, that would be.
yeah.
Yeah. Okay. So phagocytosis, you guys remember how that works, right? Pseudopods are extended out once the toll-like receptor binds to the PAM. And the pseudopod surrounds this pathogen, i.e. in this case, this is a bacteria, right? And then this bacteria will be taken in, surrounded by membrane. That membrane pinches off and become a vesicle. We call this a phagosome. Okay? And that phagosome is going to fuse with the lysosomes, and the enzymes within the lysosomes will break down that pathogen. Okay? That's basically just digestion, facilitated by the enzymes inside the lysosomes. And then if this bacteria has something useful, the cell will use it. If not, the cell will, or this cell will exocytose the fragments back out.
Did you say if it has something useful? So
I mean, whatever it is, right? Maybe it has something that's useful for the body. Who knows? I'm just saying.
I'm like, what's
Like
the
what?
scenario where that would
Who
happen?
cares? Doesn't matter. What if they have nucleotides that we like? What if they have amino acids that we can use? Right? Who knows what it is? It could be hypothetical. I could just be making this stuff up. I'm not. But anyhow, so most likely as, let's say if it's a white blood cell, and the white blood cell is consuming these pathogens, most likely scenario is that it's gonna break it down and secrete it back out. All right, there could be something that it's still kind of retained, or whatever it is. And some of that thing that it retains may allow for other white blood cells to basically now gain the advantage of having the memory of the particular pathogen. Right? So it will be processed in different ways and stuff like that. So it's sort of like a little souvenir, so you don't forget who like punched you in the face.
Would the mitochondria be like one of those things?
No, because the mitochondria in those cells will already incorporate eons and eons ago. It's not taking new mitochondria.
But you know what I mean.
Right? Because some of these particular bacteria is basically the size of a mitochondria. That's what the mitochondria is. It's a bacteria once upon a time. So therefore, if these bacteria has the ability to convert, let's say, or the ability to use oxygen to basically make a lot of ATPs, then that's how the mitochondria was incorporated. But now we don't incorporate that because we already have mitochondria. We're not going to consume bacteria and say, oh, new mitochondria. Who knows, maybe? All right. Now the second event, another event that is initiated through all of these neutrophils and macrophage activities with phagocytosis is to induce what we refer to as inflammation. Inflammation, basically, anytime you have inflammation, it is evidence that you have some kind of infection that's going on, or you have some kind of injury that is occurring inside your body. Okay? Either way, the inflammation allows for white blood cells to move to that area and therefore allow for the healing process to take place. Okay? Now, anytime you have inflammation, you will always have 4 signs associated with inflammation. And we call these the 4 cardinal signs of inflammation, which means it is always present in every single case of inflammation. These 4 cardinal signs are listed here. So the first sign is rubor, which is redness. Rubor, redness, technically it's called erythema. Okay, so let's say if you cut yourself and that area now becomes redder than the rest of the surrounding tissue. That is erythema. Okay, that's the first sign of infection. The second is called calor. Calor means heat. So if you touch that area that basically where the infection is occurring, it feels warmer than the rest of the surrounding tissue. Make sense? That's calor. Third is tumor. Tumor means swelling, or technically it means edema. So therefore, if you palpate that area that is infected, it feels larger than the surrounding tissue. It is more swollen than the surrounding tissue. The fourth sign is dolor, which is tenderness. So if you touch that area, it hurts more so than the surrounding tissue. Does that make sense? Okay, so those 4 cardinal signs are associated with that. Now, what's the difference between pain and tenderness? Because they are not the same.
Is tenderness more of just like sharp sensation?
That could be pain too.
Well, not always, like intensified feeling versus actual like pain receptors.
Sure, but then how do you break it down? Because one can be assessed objectively. The other one is a subjective report. So pain is always subjective. Your pain threshold, different than her pain threshold, different than my pain threshold, right? She can probably, if somebody cuts her, she'll be like, it hurts, all right? And then if the same cut happens to you or me, we're like jumping up and down, you know, crying for mommy and stuff like that, right? Because our pain threshold is different. So pain is very subjective. So that's why anytime you go to the doctor's office, they always have that chart with all the little emojicons and say, which one do you feel like? I don't know, I feel like that guy that's barfing, so that's number 11, right? 11 out of 10 or whatever the case is. Versus, oh yeah, I feel super happy. So your pain level at that point is 1 out of 10. Well, why the hell you come in the office in the first place? I'm wasting our time. Okay, take care of yourself. Just walk it off. All right, anyhow. So therefore, pain is very subjective. Tenderness, though, is objective. Tenderness, you have to be able to elicit that response. So when you go through the physical examination of the patient comes in and says, I have abdominal pain, and they're guarding and they're walking and stuff like that, and they're sitting there and you're talking to them, and they're talking to you like nothing's happening while they're still doing this, right? So you have them lay down, and then you start to palpate. So anytime you palpate, you always want to palpate the normal side first, just to feel what the normal side feels like. If, let's say, it's a symmetrical side, so you feel the normal side, and then you go over and you start palpating the abnormal side. If you start to touch, or let's say this, if you touch the normal side and it elicits that pain, then the tenderness is actually real. Make sense? But if you're touching the patient and you're pushing really hard and the patient is still talking to you like nothing's happening, well, maybe the pain is not really that high. So therefore, there's not a lot of tenderness when you palpate the patient. Okay, so that's more objective because that's the finding to correlate with the pain levels that's reported by the patient. Okay, so, all right. So how does this work? I'll draw this out for you guys. Now, for inflammation, there's 2 different ways to induce inflammation. You have acute versus chronic. Acute inflammation, that is inflammation that basically lasts for less than 2 weeks and resolves itself within the 2 week period. Chronic inflammation, you have inflammation that persists for more than 2 weeks, 2 months, 2 years, 2 decades, whatever the case is, right? Because you do have infections that will last for like 40 years sometimes, okay? So with this inflammation, this is how it works. So imagine you have a bunch of, let me say, this is your skin, okay? So within your dermis, you have your blood vessels. Within your blood vessels, you're gonna have a bunch of white blood cells. So one of those white blood cells is going to be your neutrophil. So neutrophils kind of look like this. And when they move around inside your circulation, they are rolling around because the blood is pushing them. So they're sphere-like, so they just basically roll around. Okay? So this is your neutrophil. Now you have another type of white blood cell within your circulation. It's much bigger than this guy. It has this U-shaped or kidney-shaped nucleus. It's also rolling around. This is called your monocyte. Okay. they're both rolling around in the blood. So this is the blood. And the blood is moving in this direction, let's just say. Okay, there's your skin. On the surface of your skin, there's a bunch of these bacteria, these pathogens. So, pathogens hanging out. And at this point, if you lick your skin, you're basically introducing, I don't know, several million colonies of pathogens into your mouth, which is okay. Your mouth is still considered to be an external surface of the body, right? In order for anything to be internal, it has to get into the blood or into the cell. So these pathogens are just hanging out outside. Now remember, your skin is intact, so it forms a nice thick barrier to prevent the pathogen from invading into the dermis, into the deeper portion of your skin. Okay? But of course that doesn't last very long because something comes along and let's say you have a penetrating wound, you have a splinter of some sort. So something penetrates in your skin, kind of break this area of your skin. When you break that part of your skin, now you start to introduce these pathogens into this area. So the pathogen enters. Now, as soon as the pathogen enters, within your skin, there are a bunch of resident macrophages. These particular macrophages live within your skin. So, resident macrophages. Okay. They will detect those pathogens, but they will be absolutely overwhelmed by these pathogens because there's not enough of these guys to fight off all of these pathogens that's entering. So they will start to eat up some of these pathogens. And once they detect and start to eat up these pathogens, well, first of all, how do they recognize this pathogen to eat them up? What do they use to attach to the surface proteins of these pathogens? The toll-like receptors, right? And on these pathogens, there'll be a bunch of PAMPs. So toll-like receptor binding to the PAMPs allow for phagocytosis to occur. All right, so they know they're gonna be overwhelmed, so now they have to call in the cavalry from the blood. So what they're gonna do is they're gonna secrete signals called cytokines. Cytokines basically means signals that stimulate cells, okay? So any signal that stimulates other cells is referred to as cytokines. Now, hovering around the blood vessel are a bunch of mast cells. Okay? Some of these signals will stimulate the mast cell. And when the mast cell is stimulated, they will release heparin into the circulation, which then basically decreases the clotting activities inside the blood to ensure that blood flow is now more efficient. The mast cells will also release histamine. And what the histamine does is that it increases vasodilation. Okay, so it dilates the blood vessel. So now the blood vessel looks bigger. Right, it dilates out. So as it dilates out, basically now, there's less resistance to this blood flow. So you have more blood being delivered to this area of the body. Does that make sense? Okay. But of course, if you dilate out, there's less resistance, the blood flow may be a little faster now. So how do you get these guys, the neutrophils and the monocytes, to now leave the circulation to move towards this infected area of the body? Because these guys are like just speeding through this area massively, okay, due to that dilation of the blood vessel. So one of the cytokines that's released by these resident macrophages, and also is a combination to these injured tissue as well. But let's just say from the resident macrophages, there's another cytokine that basically gets directly put into the blood vessels or the bloodstream. These cytokines act as chemotaxis. So it's the cytokine that basically acts as an attractant to these white blood cells. Okay? So therefore, these chemotactic type of compounds will stimulate these white blood cells to now move closer to the walls of the blood vessel. Does that make sense? So let's say now you're being attacked by these pathogens. You're getting jumped. You're like, dude, I gotta call my homies. I gotta call my buddies. And they're somewhere else. So you send a text to your friends, and now they're in their car, driving down the 101 at 150 miles per hour. Oh, I don't know what kind of car that, maybe 198 miles per hour. You gotta be safe, right? Keep it under triple digits. So as they're now madly rushing toward you, they don't know where you are. So therefore, this text that you sent them tells them exactly where to exit along the way. Otherwise, they're just gonna overshoot this area and that's it. You're dead. Okay? So the chemotactic chemicals is gonna stimulate these neutrophils, and the neutrophils and the monocytes will start to move closer towards the walls of the blood vessel. Now, as they move closer to the walls of the blood vessel, they will attach to the walls of the blood vessel. As they attach to the walls of the blood vessels, they now start to crawl along the walls of the blood vessel. Because they can no longer roll around that massively, okay? So as they attach to the walls of the blood vessel and they start to crawl along, we call this process margination. Okay? So the next step of this is that once they receive this chemotactic type of compound, they will start to marginate along the walls of the blood vessel. Now, as they are crawling along the walls of the blood vessel, there are potential gaps in the walls of the blood vessel because the blood vessel has dilated out. So therefore, once they reach an area where there's a gap that's big enough, these neutrophils will squeeze themselves out into that interstitial space. Okay? So therefore, they are now squeezing themselves out. So here's the nucleus here. Okay, so they're squeezing themselves out. And we call this process transmigration. They are now migrating out of the blood flow into this interstitial space where the infection is taking place. Okay? So these three processes are called chemotaxis. The second one called margination. And the third is known as transmigration. Are collectively called diapedesis. Okay? It's basically the steps to get the white blood cells to leave the bloodstream to move into the infected tissue. This also has another name, and that name is extravasation. Okay. Extravasation, basically the vasation refers to the vessel. Extra means these white blood cells are now leaving the blood vessel. Okay. All right. Once transmigration has occurred and these neutrophils are now out here in the interstitial space, they will now move toward the area of infection. How do they know where the infection is happening? Or because they follow the chemotaxis sent out by the resident macrophages. These guys are still there. They're being pummeled, but they're holding tight, right? They're like, dude, just beat the shit out of me, I don't care. My friends are coming. You're gonna be in trouble. So now, these neutrophils start to surround all these guys. Okay, so they're no longer round and spherical, they're now sort of like an amoeboid type of cell, because they're moving as they're extending out their particular cytoplasm and stuff like that. So the neutrophils surround these pathogens and they start to phagocytose these pathogens. That's what they're there to do. Once they start to eat up these pathogens, they will now release a substance and these substances are sort of like these protein structures that surrounds this infected area. Okay? So this protein structure is referred to as the neutrophil extracellular traps. Okay? So neutrophil extracellular traps, otherwise known as the nets. Maybe we'll take this into a lowercase s. Okay. So once the neutrophils phagocytose these pathogens, they release the net. And this net basically just form a protein layer to prevent these pathogens from invading deeper. Once they form the nets, the neutrophils die. They go through apoptosis, popping all over the place. And when they die, they form pus. That's why pus is white, because it's a bunch of white blood cells dying. Okay? So once they form that pus, now all that pus includes fragments of neutrophils and hopefully fragments of these pathogens as well. So all these pathogens and these neutrophils are now dead. All right, what are you gonna do now? Because you have a bunch of pus around this area, right? So therefore, every time you get an infection, you will produce some degree of pus. Right? If that infection requires the neutrophils to get in there and clean up all that stuff. All right, the next thing that happens, and of course this happens kind of simultaneously, right? Once the neutrophils go through this overall diapedesis, the monocyte also does the same thing. Okay, so imagine this thing's happening at the same time. So you have the monocytes doing the same thing. They go through margination. They go through all of this type of movement. They also squeeze themselves out through transmigration. Once the monocytes leave the blood vessels, they become macrophages. The macrophages will now move into this particular area and start to surround this area. As they surround this area, they will now start to eat up all the pus, which includes all the dead neutrophils and all the dead pathogens. And once they do that, the infection is resolved. Make sense? If all of this taking place can resolve the inflammation within 2 weeks period of time, we call this an acute inflammation. If this persists, because some of these bacteria is so hard to kill that you will not be able to kill them. So if you cannot kill them, they may persist. And therefore the neutrophils, as they come in, they will continue to die. And the macrophage comes in, they try to eat up these things, but they can't clear these pathogens. So if that inflammation persists more than 2 weeks, because these pathogens are very hard to kill, we call that a chronic inflammation. Okay? So if you have some kind of infection and you produce pus, and then the pus eventually stops within 2 weeks, and your tissue starts to heal, that's an acute inflammatory response. If you have some kind of wound and it festers, and basically pus is draining out, and you think it heals, but then pus continues to be produced and drain out after 2 weeks, that's a chronic infection. Because you have what we call a chronic inflammation going on. Now, once you have chronic inflammation, the macrophages, they sense that. They're like, you know what, we can't kill these guys. What we're gonna do now is form tight junctions with each other. So they basically lock up. And once they do that, they will now produce a thick wall called a granuloma, right? So they recruit fibrous tissue, fibroblasts, to basically form this particular thick wall to trap all of these things. So within your granuloma, there'll be a huge well of pus, and we call that an abscess. Okay? If you ever had an abscess, the only way to treat that abscess is to remove all the pus. How do you remove the pus?
Pop.
Sure. What if you have a huge pocket of pus? what if, let's say, here's the patient's leg, right? And you see a ring of inflammation here, right? And you see like an opening and pus is like draining out of it. Okay. So there's a ring of erythema, redness and stuff, swelling, there's pus coming out of it. But if you look at this and you can't see this, but let's say internally, so underneath the skin, you may have one reservoir of pus, and you may have multiple pockets of pus. That's what. So how do you remove that? You gotta dig it in. If you remove only this pocket, the infection will come back as soon as you remove this. So what do you need to do? You get a hemostat. Like the needle of the hemostat is like about maybe 2 inches long. And you go in there and you open up this space. And you dig through this and you open up that space. So then you communicate, you allow these two spaces to communicate with each other. And you go in there and you dig up till you continue to dig until you get all these pus to become one big pocket of pus. What do you think the patient is gonna be feeling? If you don't hold them down, they will kill you. Literally, they will kill you. The pain is excruciating, right? Imagine you dig into flesh. No amount of anesthesia will penetrate that pus. So therefore, yeah, there'll be some degree of numbness around here, but in here, if you still have any kind of pain receptor intact, oh man, the patient is going to do everything they can to prevent that from happening, prevent you from doing that to them. So I remember when I was in Bakersfield, Bakersfield, it's not a lot of stuff to do, right? People get bored, so they use meth all the time, right? So I was in the pain clinic, and the pain clinic deals with a lot of meth patient that is recovering. So one of this particular individual that came in one day, he has this huge abscess on his thigh. And so I was there with the physician, and the doctor said, hey, you know, this is a perfect opportunity for you to kind of practice on this stuff. So I was like, all right, well, what do you need to do? Well, okay, first, let's remove the pus. We gotta keep in mind a bunch of these particular pockets. So he said, all right, here's the hemostat. Just go in there and start breaking it up. Just look for any space that you can penetrate and start to tease that apart, okay? So you got 2 MAs, these big, you know, medical assistants who come in, hold this patient down. Now the patient wasn't a big dude. He's maybe about like 5'9", but he was pretty stocky. It's like 245 pounds or something like that, right? He's big, he's like a linebacker looking dude. So they held him down, and he looked at me, and he said, sorry sir, I'm gonna do some pain on you. I'm gonna cause some pain, but this is necessary because we gotta get the pus out. He's like, you better do it quick. So all right, I'll try and do it quick. So before I got in there, what do you need to do? Because remember, this is sort of like a little tip of the volcano. You can't insert the hemostat in there. That's bad. That's just breaking skin. So what you need to do is cut this open. You gotta get a scalpel and just slice through it. Okay. So before, so they gave me the scalpel and say, okay, go ahead and cut. And before I cut, he's like, wait. Think about a volcano. What happens when you start to open up the mouth of a volcano? All the pressure is gonna shoot out at you. I was like, okay, good. Kind of like stood to the side, like, you know. So I cut into it, and sure, pus was shooting out. I mean, from where you're sitting, pus was hitting this wall. That's how much pressure was there. I mean, I had to burn my scrubs. Because I mean, some got on it, like, yeah, I'm not gonna wash this stuff out. I can't reuse this, right? So anyway, we cut it, it opens up, and then we took the hemostat, went in there and started to open up all of this abscess. Oh my God, this patient was just screaming, cussing. Find you and kill you, all your family. It's okay. Good luck. We got a lot of equation. So anyhow, we did that, right? So now you clear all this pus. So let's say you clear all of this out. Now what do you have? You have a gaping hole. So what do you do with this hole? You can't just leave it like that. Like, oh yeah, go home, take a shower, fill up with fluid. No, you pack that sucker with gauze. So there's a sterile gauze that's prepared for this purpose, it's, laminated with something. So you basically take another hemostat, you take that gauze and you just pack this crater, right? You pack it all the way up to the top, and you put another gauze on it to kind of close it up. Tell the patient, go home, just, do your normal activities, just try not to get that thing wet. You take a shower, sticking your leg outside, whatever the case is, and you bring the patient back about 3 days later. And we take it, bring the patient back, the wound now is healing. But the gauze is still in there. That's a foreign object you have to remove. So, we now have to remove all that gauze, which is actually more painful than when we were digging in the first place, because
So
now
blood
all your
clots.
nerve endings are being reestablished. So you're removing that, the patient's screaming again, and then you repack it again. And you do this repeatedly until this heals. And for that patient, it took almost 3 months to heal. So, anyway, just, if you use drugs, make sure you smoke it. Don't inject it.
Was it from?
That's the story.
Was
Alright.
it from like a contaminated needle? Or?
Pretty sure. I mean, obviously, these guys are not gonna sterilize the needles, they're not gonna use new needles every single time. It's a needle that he says I'm using, I'm not sharing with anybody, so he's using the same needle to jab himself every single time. Thinking that's okay, obviously, it's not. Alright, any questions about that? Okay. Alright, let's stop here, we'll continue with this next